Hi, my name's Kelsey McDonald, and this is assignment number 3. For this assignment, we chose a 72-year-old male. He was getting a video-assisted thoracic surgery for a right upper lobe lobectomy. For pre-assessment, I found out that the medications he was on was a fairly short list. He was on aspirin, which he had stopped 9 days prior. He was on metoprolol, atorvastatin, and meloxicam. He had no prior allergies that he had known of. His cardiovascular disease, he had an MI about 20 years ago with some hypertension that is now just medically managed. He can walk 2 flights of stairs without any shortness of breath or orthopnea. Respiratory-wise, he was an ex-smoker. He quit approximately 8 years ago. He was a 60-pack year smoker. He is diagnosed with COPD. They had done some PFTs prior that showed a 92% FEV1 and a 59% diffusion capacity, so moderate severity. Gastrointestinal-wise, he had no reflux, no hiatal hernias, no liver disease. He was a non-drinker. His previous surgeries, he had just had lung biopsy 2 months ago and an embolectomy as well. No issues with anesthetic that he's had previously, as well as no family history of any issues with anesthetic. Hematology-wise, he did have a DVT in 2015. Gastrourinary, he had no kidney issues or anything like that. Metabolic and endocrine, no disease there. He did have some lipidemia, and he's not obese. He had a BMI of 25. His weight was 79 kilograms and height of 177 centimeters. CNS-wise, he had no issues, no previous CVAs or TIAs. Musculoskeletal, he does have osteoarthritis in his wrist, which is treated. So my concerns here is the right upper lobe nodule, his previous MI, hypertension, dyslipidemia, his diagnosis of COPD, his diffusion capacity of 59%, previous DVT, along with his osteoarthritis. I gave him an ASA of 3. His surgical needs, we will place an art line. He'll have 2 IVs, one of a bigger size in case he needs to get some blood product. He'll be placed in lateral positioning on his left side, and he will be ventilated with 1 lung ventilation, and a double lumen tube will be placed. Possible risks for us would be prolonged air leak, collapsed lung atelectasis, arrhythmias, excessive bleeding, difficulty ventilating and oxygenating, especially with his COPD and diffusion capacity, pulmonary embolism, chance of converting to a thoracotomy, and post-op pain, which the surgeons had stated they'll put a paravertebral block in for. Pre-treatment options, we're going to try to keep it with just midazolam. On airway assessment, the patient had a Mallampati 2. He had a normal thyroid mental distance. He had normal neck mobility. He had normal mandibular protrusion and a good mouth opening. Furthermore, he had upper dentures and he had quite a few missing teeth on the bottom. So the plan is to get the patient in the room. We're going to put all the monitors on him, heart rate, SpO2, and blood pressure. We'll then get an IV, probably an 18 gauge, just to get him off to sleep. He'll be induced with propofol, remifentanil. We'll give him some lidocaine to ease the pain of the propofol, and some rocuronium. Emergency drugs will be drawn up, such as phenylephrine, atropine. We'll pre-oxygenate the patient for about 2 to 5 minutes. We'll make sure that we can bag the patient once he's off to sleep. And then a 41 double lumen tube will be placed with a 39 as backup. I'm going to try direct first, but we'll have a VL, just CMAC in the hindsight, just in case it's needed. We do have bronchial blockers as well, in case that a DL can't be done, or sorry, double lumen tube can't be done. And we'll have as well an LMA in case we need to ventilate while we get everything else ready in between. Once all that's done, we'll check with the fiber optic bronchoscope just to make sure it's in right placement. Following that, we'll get an arterial line and another IV. We'll place a temp probe and we'll get a nerve stimulator all placed. We'll then put the patient into left lateral position, and we'll once again check with the bronchoscope to make sure the double lumen tube is sitting where it should be. We'll get a lower body bear hugger placed on the patient and make sure that he's padded correctly so that there's no damage to any nerves during the surgery. We will also give Kefsol for antibiotics and Deltaparin just because he has the AFib. After he's positioned and we recheck the tube with the bronchoscope, we will start one lung ventilating and pulmonary isolate that right lung. So we'll ventilate him with tidal volume from 4 to 6 mils per kilogram. We'll make sure he's on a PEEP of at least 5 and high FiO2 of 100% to start. We'll come down on that as we can. Maintenance-wise, we'll be giving Ringer's lactate. We'll keep him on sevoflurane with a MAC of 1. We'll give ROC PRN, and we'll have ephedrine and phenylephrine PRN as if we even need it. And for emergence, we'll give him ondansetron, hydromorphone for pain. As I had mentioned earlier, a paravertebral block will be placed by surgery. We'll do an ABG during the maintenance phase to make sure we're doing okay. We will permit a little bit of acidosis, so 7.3 to 7.35 is our aim, with a little bit permissive hypercapnia as well. We will try to extubate before we bring him to PACU. We'll suction, extubate, and just go right to a simple mask as long as permissible. And the plan is for him to go to IMCU afterwards. So the patient came into the room. He wasn't nervous at all, so we actually didn't have to give the midazolam like we thought we may have to. We put all the monitors on him. I got an 18 gauge IV, Ringer's lactate were started. We then went and we pre-oxygenated him for about 5 minutes. After that time, we gave his induction medications. He got 50 milligrams of lidocaine, 1 mic per kilogram of remifentanil, so about 80 micrograms. Propofol, we did 1.5 milligrams per kilogram, so about 100 milligrams, and 50 of rocuronium. When the patient was asleep, I tried to bag a little bit. He was an easy bag mask ventilation. So I then put the 41 size double lumen tube in place into the left bronchus, and then secured the tube. We had bilateral air entry, end-tidal CO2 confirmation, and then the resident took over and bronchhed, and positioning was fine where it was. While he was bronching, I put in an arterial line and another IV. We put in a 16 gauge just in case there was bleeding. At this time, a temp probe was also placed, along with a nerve stimulator as well. We then moved him into the left lateral position and patted all extremities to make sure that there was no nerve damage of any sort. We then bronched again just to make sure that the double lumen tube was still in the left bronchus, which it was. And from there, we started one lung ventilation. So we deflated the tracheal cuff and put up the bronchial one. And with bronchoscopy, we made sure that the cuff was in the correct place. And we put the ventilation parameters down to, I think it was 5 mils per kilogram, so about 400 mils. We put him on a respirate of 18 just to try to get an end tidal somewhere in close to the 45 range. We started him on an FiO2 of 100 and SpO2 was 95 with that in the beginning. Yeah, and we put him on a PEPA 5. We put a lower body bear hugger on him as well. We turned the sevoflurane on and we titrated it to about a MAC of 1. Throughout the procedure, we did have to give a little bit of ephedrine. I think we gave about 10, not a whole lot. And we had to give about 150 of phenylephrine as well. Throughout the procedure, during the maintenance phase, we did an ABG. The ABG had a pH of 7.32, PCO2 of 48, with a PaO2 of 81. We were happy with that because it correlated with our SpO2 of 95%. And that was actually done on the same settings I had mentioned earlier, but with an FiO2 of 65. Emergence-wise, we gave 4 of ondansetron. We gave altogether 1 milligram of hydromorphone for pain management. The surgery team did a paravertebral block. There was no issue reinflating the lung following, and we were able to reinflate the tracheal cuff and deflate the left bronchus without any drop-in sats or issues with ventilation. The patient was easy extubatable. We suctioned prior, extubated, and went straight to a simple mask. The patient then gone to PACU and then to the IMCU.